I'm Dr. Allan Perel, and this is Conversations in Medicine. I'm Dr. Allan Perel. This is Conversations in Medicine, a program devoted to cutting-edge medical topics for the Staten Island and tri-state community. Today we're going to be talking about orthopedics and what's new in orthopedics. We all have a lot of joints, and orthopedics is the surgical subspecialty that deals with joint pain. If you think about it, there are hundreds of different joints in the body, and if anyone looks at the table in a few moments, we have a lot of joints over here. Some of them are even partly neurological joints like your spine, but every place where two bones come together, something could hurt. And for us weekend warriors, almost every time something does hurt. My guest is a good friend and prominent physician and orthopedist on Staten Island and in Brooklyn.
Thank you.
And he's a wonderful orthopedist who's helped me and my family over the years. I want to say thank you. This is Dr. John Linsalata, who's board certified in orthopedic surgery and orthopedic sports medicine. Pleasure, John. Thank you for coming.
Thank you.
So for our audience, tell us, what's an orthopedic surgeon?
Well, an orthopedic surgeon is a physician who specializes in treatment of musculoskeletal conditions. And that can range from bones and joints, like we talked about, to muscles and tendons, ligaments, and nerves. So that it encompasses the whole area and involves evaluation of patients, treatment, whether it be surgical or often non-surgical, including rehabilitation and injury prevention.
So someone who comes to the orthopedic surgeon, with the word surgeon there, most times doesn't leave the office having surgery.
Correct. I think most patients don't have surgery. In my practice, probably less than 10% of patients I see require surgery. Most conditions can be treated non-surgically with medication, exercise, therapy.
How do you know when to go to an orthopedic surgeon?
That's a good question. I think you have to have a sense of your own body or your child's body if you're talking about your children. Everybody gets pains here and there. I think when you start getting pain that's more persistent or more extreme, is a reason to go. When I have someone who has an injury and I get a call on the phone and people ask me, should I go to the emergency room? One of the things I'll say, if you have an injury and you see a deformity, or if you're having numbness or difficulty bearing weight on the lower extremity, it's something to consider having it evaluated more urgently as opposed to waiting for an appointment in a couple of days.
We all think about orthopedists as when one of our children or ourselves had an accident, and we think of a cast that goes from here all the way up to here. Everybody writes their name on it with magic marker, and everybody talks about it, and everybody in school empathizes with you. But tell us a little bit about what's going on with new things in surgery. Mm-hmm. I know we've got some models up here, and there are a lot of things, arthroscopy, and I want to even give some definitions. As in all surgical techniques that we're seeing in medicine, we're using smaller holes, thinner instruments, being able to do more without opening up as much. And that hopefully leads to less disability and shorter recovery times. So tell us, we have a bunch of different joints here. Maybe you can give us a little idea of what we have here, and we can go and see what we go. Everybody likes a picture.
Surgeries in general are becoming less invasive, whether that means arthroscopic or even through open incisions. A lot of the procedures are being able to be done now through smaller open incisions with less dissection, less injury to muscle. So I think that's one of the something that's evolved over the years. I think our treatments are evolving in every subspecialty, and I think every joint has arthroscopic surgery like you brought up. I think probably started probably in the early 80s, but it evolved where people were looking through a camera into a joint. Now it's become more sophisticated. We're looking at 4K television where you can almost see the blood pulsing in capillaries. So the imaging has gotten much better when we're doing arthroscopic. The techniques have improved and the equipment's improved. So working with engineers to kind of devise new equipment that make some of these smaller incisions and arthroscopic procedures more applicable. I think we're doing arthroscopies at every joint. I think still probably the most common areas we see arthroscopic are in the knee, probably followed by the shoulder. I think
What's arthroscopy?
arthroscopy is, well, scope is meaning you're looking with a camera and a smaller instruments. Arthro means joint. So you do laparoscopic would be a scope of the abdomen. Arthroscopic is a scope in a joint. So we're usually using punctate little incisions, and we'll go in with a camera in one portal, as we call it, and then we'll use instruments in other accessory portals to perform surgery. So in the knee, for example, the most common arthroscopic procedure in the knee is meniscus surgery.
What's the meniscus?
The meniscus are the cartilages that sit between the bones. So I'm going to pick up a model of the knee we have.
So that's a model of someone's knee.
This is a model of a knee. And so we have the thigh bone extending above, the shin bone extending below. Between the femur and the tibia are these two we call semilunar cartilages that are almost like C-shaped, and they sit between the bone and act as a cushion and help improve the congruity of the joint and kind of help transmit the stresses from one bone to the other. It's almost like a ball bearing, and it can tear fairly easily. When that tears, it can cause catching in the joint. It can cause swelling, and there are different reasons the meniscus can tear. We can see it as a sports injury. So a traumatic meniscus tear is probably something we'll see in a younger patient. It can be very symptomatic and often require surgery. We also see degenerative tears, particularly in older patients, where the meniscus just frays and wears out. I think we've learned also through recent studies that surgery on those degenerative tears is probably less necessary. A lot of those can improve without surgery, with therapy and rehab or potentially a cortisone injection. So surgery is not always necessary. But the meniscus is between the two bones, and that's probably the most common arthroscopic surgery that's still performed is meniscal knee surgery.
So we have a knee here. So while we're talking about the knee, we had one of our wonderful camera people to ask us a little while ago, when you hear that someone gets an injection in their knee, what does it mean? Well,
an injection means we're putting a needle in the knee. So I think the most common injection still probably in the knee is cortisone. Everybody knows cortisone goes back 50 years. It's a steroid injection in the knee.
Anti-inflammatory.
An anti-inflammatory to reduce inflammation. And that can be used in an inflammatory condition like rheumatoid arthritis, but even someone who has osteoarthritis with an acute flare with swelling. After that, I think that we've been using hyaluronic acid injections. You hear about that more commonly. We call visco supplementation. Hyaluronic acid is a material that your body uses as a building block for cartilage, although we know that you really cannot rebuild cartilage once it's damaged. We've not really gotten to the point where we can grow cartilage or regrow it back in a joint and cure arthritis. But injecting these hyaluronic acids can actually stimulate the body to create its own growth factors to reduce inflammation. And hyaluronic acids can work that way to allow the body to reduce inflammation on its own. The problem, it doesn't work in everybody. And probably half the patients get relief and the other half don't have much relief.
Because it sounds like it makes sense. If you put back in an area where it's almost bone on bone or close to bone on bone, if you put back some lubricant or some type of gelatinous material, it should lubricate the system.
It makes sense, but doesn't always work. I think that some of the newer things, which is an exciting newer field in orthopedics, is biologics. And we're seeing people injecting now PRP, platelet-rich plasma, or stem cells, which is popular in all fields of medicine now. The problem with those is that they've shown some success, but I think there's still more research to be done. And we haven't shown that they're necessarily better, for example, than just rehab or medication for certain conditions. And they certainly do not rebuild cartilage. So I think some people come in with the expectation that, well, if you put stem cells in, my cartilage will regrow and I won't have arthritis. I think stem cells can work in a similar way to hyaluronic acid injections, where they can potentially stimulate your body to create its own growth factors that can reduce inflammation and help with pain, but not regrow cartilage. We don't really have that technology yet.
So back to the question, we have everyone here. Where do you actually inject?
Well, so there are different ways of injecting every joint. I mean, the most common way to inject the knee joint is with the person's leg flat and just putting the needle under the patella. The other common way is how we do arthroscopic surgery, is with the knee bent a little bit and putting the injection from the front of the knee. So I think the injection technique is something you just learn over time. Now, some people will use like an ultrasound or X-ray to help improve the accuracy of their injection. I think depending upon how many you do, as you get more experience, I think most of these can be placed at least in a knee joint without imaging. And it's not a specific spot you need to hit. Some people come in and say, well, my pain is over here. Why are you putting the injection here? Well, basically it's one big joint and it's liquid. So you put the liquid in the joint and it can then diffuse around the joint. You're not necessarily putting it in the spot in the joint, but you need to make sure you get it in the joint. And that's where sometimes an ultrasound can improve your accuracy, particularly in a smaller joint. In the knee, I think most of these can be put in freehand.
So tell me, so we went for the knee. It's sort of, so I think we're going to do this as we would do grand rounds at the hospital. This is going to be the knee portion, and then we'll go to some other joints.
Fine.
End stage, someone with severe osteoarthritis, degenerative changes, they say bone on bone. What does that mean, and what treatments are really available?
Yeah. So, arthritis is essentially wearing down of the articular cartilage in the joint.
Which means what?
So cartilage is a smooth material found at the end of the bone that creates our joints. So similar to when you see a chicken bone, the pearly white material at the end of the bone, that's articular cartilage. And when that wears down, that's arthritis, when it's a degenerative process. You can get cartilage injury traumatically. More commonly, we'll just see natural wearing down of the cartilage, just like your tires wear down in your car. It's a mechanical substance. It has a very low coefficient of friction, so it has a very smooth surface. But when it wears down, it gets less smooth. You get more friction, and it starts the process of arthritis. And as the cartilage wears down, you get more stresses applied to the bone and more pain in the joint. And that's basically what arthritis is. I mean, the gold standard treatment for arthritis still, end-stage arthritis, bone on bone, is a joint replacement. And knee replacement is a procedure which works very well. It involves reshaping the ends of the bone and putting a prosthesis on to kind of almost like a capping of the bone. And most commonly we use a bone cement, which is really more like a glue, polymethyl methacrylate, and we use that to cement the prosthesis onto the bone and create a new joint surface. So now you have metal articulating with plastic, and this is a very good procedure with a very high success rate.
It's gotten better over the years.
Absolutely.
Devices have gotten better, the technology and the engineering has gotten better.
Yes, and I think probably some of the newer things, probably in knee joint replacement, has even been pain management. I think one of the biggest things which inhibits patients from going back to having a second knee replacement if they've had one is the pain involved. We know that it's a painful procedure. I think pain management techniques after surgery have gotten much better, using local anesthetics in the joint and non-steroidal anti-inflammatory medications and injectables to reduce pain to make the rehab easier for patients.
So patients ask me all the time, and I'll talk to you that in my own practice as a neurologist, I hear this, and I don't know the answer to it. So maybe I'll ask you. Why, if someone's walking, you walk on 2 feet, why would one knee go bad before the other knee? One knee needs a joint replacement, the other one doesn't.
Yes, I mean probably the most common reason is injury. Arthritis is a degenerative process which can occur over time, just naturally. So that you would expect to be in both knees. One of the bigger risk factors for it is potentially weight. So people who are overweight will put more stress across their joint and more apt to get arthritis, more commonly in both knees. But if we have an injury in the knee, we know that will accelerate the development of arthritis. So for example, if you tear your meniscus, you're much more likely to go on to get arthritis in that joint, whether you have surgery or you just leave a torn meniscus. Once the meniscus tears, it loses some of its function as far as the ability to transmit stress across the joint and act as a shock absorption. Therefore, the cartilage is going to wear down more readily. So we also know that the original techniques of removing the torn meniscus can actually, particularly removing the entire meniscus, can accelerate the development of arthritis. Most arthroscopic procedures, when we do meniscus surgery now, we trim only the torn portion and try and maintain as much of the remaining meniscus as possible to limit the amount of arthritis. Or, if possible, we repair the meniscus. We actually go in and put sutures in. That's a procedure which is done more commonly with traumatic meniscus injuries, particularly in younger patients. And it has to have just the right proper configuration to allow it to be sutured. But arthroscopically, we can go in and put sutures into the meniscus and repair it and reattach it to maintain the structure and the function of the meniscus.
So let's go over, you brought so many wonderful models here, so let's see if we can go through them quickly. Let's grab a hand. This is a hand, so this is not a horror movie, so people who watch this think that it's a different channel. So tell us, what do orthopedics do with regard to their hands?
Yeah, so I mean, orthopedics, we have subspecialists who do just knee surgery. We have subspecialists who are trained specifically in hand. That is a subspecialty field. But I think most orthopedists treat some conditions in the hand at least. So, the most common things we see are traumatic injuries such as fractures, and just degenerative injuries, issues such as arthritis, but also carpal tunnel syndrome, which is a degenerative process or can be a traumatic process also. And it's something that we often see together and treat together with the neurologist, where patients will have numbing and pain in their hand. So that's a condition which is commonly treated both non-surgically in conjunction with neurologists and primary care doctors even, and then surgically by orthopedic surgeons and hand surgeons, where we can actually physically go in and take the pressure off the nerve.
So you would actually cut over here to take the pressure off the nerve.
Correct. So what happens in carpal tunnel syndrome is the median nerve, which in the image here is the little yellow structure here that's running underneath this ligament, gets pressure on it because of inflammation in this, we call this carpal canal. So there's a space between the bones, a ligament that covers those bones, and it's a fixed space. When the other tissues in that space get enlarged, the flexor tendons get inflammation in them, there's less room for the nerve, and the nerve gets compressed, and people will get numbing and they'll get pain. So surgery will go in and just release that ligament, which opens up that space and creates more room for the nerve and decompresses it.
And it's interesting neurologically, if you don't do it, you'll get atrophy of some of the muscles, weakness, difficulty opening up a jaw, and numbness that keeps people up a lot. And what the sad part is, once the muscle is atrophied, rarely does it come back. Correct. So we really, many of time, downplay it, but we really shouldn't, because really, if you think about how functional our hands are, how important they are, that's important.
Yes.
So I'm going to ask you a question from my son, Evan, who's an athlete, and I'm sure your daughter, who I know very well, who's an athlete. What happens to people's fingers when they play basketball?
Well, hopefully nothing, but unfortunately, all too commonly, we see injuries in the hand. And the most common thing is just a sprain, a jammed finger. So people will come to me and say, I jammed my finger and I pulled it out.
Right, they always do. They come back to me. My son comes, we're all taped up 3-4 fingers at a time.
Yeah, and I'm not a big advocate for pulling it if you don't know what's going on. I think that if you dislocate a joint, pulling it can reset it back in place. But sometimes it's best to know what's going on before you just go randomly pulling on the finger. I think the most typical thing we see is just a sprain, and pulling on it really doesn't help that at all. It may actually aggravate it further. So the more common thing we'll see is when you sprain the fingers, is just the ligaments get stretched and they get inflamed and they get stiff. So that's probably the more common thing we see. Less common injuries are fractures, and they're not always easy to distinguish by exam. I've been fooled myself, where you're looking at someone on the court and you say, it's probably just a sprain, but let's do an x-ray just in case. And sure enough, you see a little chip fracture there. And that can sometimes change the treatment. So I think in the finger is an area where, with a significant injury, with significant swelling, I'm more apt to do an x-ray and to determine if there's a small fracture.
When playing sports, and maybe we'll transition a little bit, what could kids do, teenagers, weekend warriors do to try to prevent injury?
Well, I mean, that's a kind of a broad topic. I think, in general, injury prevention is you have to have an understanding of the sport. So, when you're talking football, proper technique and proper tackling technique, for example. Not
just don't get your head involved. That's what I'm worried about.
Exactly, head in general, but not going in with your head down, where you're more actually have a flexion injury and cause nerve spinal injury. whether it be, baseball and pitchers learning proper technique, where when they're throwing the ball, we tell kids to kind of make sure they're coming up over the top, and they're throwing from this position and not letting their arm drop down, where you're more apt to get injuries in the elbow. We've learned, for example, in Little League here on Staten Island, it was a very exciting summer. We do see a significant amount of overuse injuries in children who play baseball related to their shoulder and elbow. And I think that we've come a long way in our understanding of that, for example, in limiting the numbers of pitches. And you see how in Little League, when they were planning out their strategies, the number of pitches they're allowed and how much rest they have to have in between, and determining, well, you can have them pitch, 85 pitches today, and that's the maximum, but then they'll need, 3-4 days of rest, depending upon the child's age. But if we limit it to 65, we can get them back a little quicker. So they're limiting the total number of pitches per game, but also the number of pitches per week, essentially, over a certain period of time, to reduce the risk of injury. We also talk about proper technique again. When do you introduce, curveballs, which can have a little bit more risk potentially?
Let's go over what you brought. If you brought all these things in here, we're going to go over them, I promised you. So we're going to go joint by joint. We've got about 7 or 8 minutes. So let's go over each joint and see what they do. So if everyone to know.
This is the shoulder joint. So when we talk about the shoulder, most people, the main joint of the shoulder is what we call glenohumeral joint, where the humerus, the arm bone, meets the shoulder blade or the scapula. But the shoulder also has a joint where the shoulder blade itself can actually rotate on the thoracic, so they call it the scapulothoracic joint, and then there's the clavicle articulating with the acromion. So it's made up of these
and big
3
muscles
different areas.
there too,
and big muscles that support the shoulder. So common injuries we see in the shoulder include rotator cuff tears,
That's a muscle tear, basically.
The rotator cuff is a muscle, but the portion that typically gets injured is the tendon, exactly. So more common injuries here are the tendon tears. We also have the biceps. You'll see injuries in the biceps in the shoulder. So people don't realize, well, my biceps is here. Well, the biceps, what we call the long head of the biceps, actually runs in the shoulder. It runs across the shoulder and attaches on the glenoid, on the cup side of the shoulder, and we'll commonly see injuries in the biceps tendon. And in athletes, we'll see injuries where that labrum attaches, the superior labrum in the shoulder. And that's something that arthroscopically we can go in and actually repair the labrum. We can go in and repair the rotator cuff and fix these problems now arthroscopically.
So I think for our audience, you see how much anatomy the orthopedic surgeon has to know. Where everything attaches.
Yes, well, because there's so many different joints, and each has different ligaments and tendons and how they're involved. And I think the key thing is understanding the anatomy when you're dealing with the structures, and then the function that comes along with it.
So let's go take, what else do we have?
All right, so here we have
a
foot and ankle. So the ankle joint is the leg bone, so the tibia and fibula.
And we're not going to break into song.
That's articulating with the talus. So that makes up our ankle joint, and we have the malleoli, which we talk about ankle fractures, a lateral and medial malleus, where people fracture their ankle. And then we have the remaining foot, and we often divide it into what's called the hind foot, which is the talus, or subtalar joint, and the midfoot and forefoot. So
back and the front and middle.
Exactly. And there are different conditions that affect each part of the foot. The foot is an area where orthopedic surgeons treat, but also podiatrists. So there's an overlap in the two.
So the two things everybody asks me about, heel spurs. We'll go do that one first.
Sure.
What's a heel spur?
Heel spur, and actually, it looks like this heel actually has a spur on it. So this is a heel spur is on this calcaneus, the heel bone, an extra piece of bone that can grow off the end of the calcaneus. And that can be associated with something called plantar fasciitis.
And that's the second word.
Yes, inflammation in the fascia. And quite commonly, you can see heel spurs without plantar fasciitis, and you can see plantar fasciitis without the heel spur. So the heel spur is certainly not the sine qua non for plantar fasciitis. But it's a very common condition, something you typically see in probably after age 30. You don't really see this so much in young athletes. And just a process over time where that fascia inflames and becomes painful. And people will get up, first step in the morning, and they'll say, I have pain in my heel. And after they sit and they first get up, they have pain in their heel. A very common condition.
And we hear about famous athletes, particularly large athletes, having stress fractures.
Yes. Stress fractures are common in the foot in runners. We see them in the military from, they used to call it a march fracture from marching. They would get a fracture in their metatarsal bone. That's where most stress fractures in the foot occur. The metatarsals are the longer bones extending from this midfoot into the forefoot, connecting the two. And you'll get stress fractures of these metatarsal bones. We'll see it in runners and who just suddenly will start developing pain in the middle of their foot. And that's a concern. If you start having pain that's persistent, it's probably not a good idea to try to run through it. You have to listen to your body. If you have
no pain, no gain.
We tried to limit that moniker in the sense that I think that you have to listen to your body. If you have pain, you need to slow down. Adjust your training program. So a runner, I'll tell them, get on a bike a little bit and start cross training or swim. Take some of the pressure off. Check for proper shoe wear. Those will show up on an X-ray, but sometimes we'll need special imaging such as MRI or bone scan to determine if someone has a stress fracture.
Last one, we only have a couple of minutes left. Let's look at someone's hip.
Okay. So this is actually the whole thigh bone here. Actually, this is just the hip by itself. This is the hip joint. This is the pelvis bone. And this is the femur bone, and this is the articulation between the two. This is the hip joint. Probably the most common thing we see in the hip is arthritis. Unfortunately, that's more the end stage of hip issues that teenagers or young adults will have. But that's still probably the most common surgical procedure on the hip is a hip replacement, which is a definitive treatment for hip arthritis. And similar to what we talked about in the knee, it's essentially a resurfacing procedure on the cup side. And on the femur side, it could be resurfacing, but more commonly be an implant, a prosthesis that gets inserted into the canal of the femur to create a new joint.
And how does one determine what kind of procedure? The orthopedics, are there rules about who gets resurfacing and who gets replacements?
There's no rule, but there are guidelines that we use. So I think we're more apt to consider a resurfacing in a younger person who has better bone stock. I think there's a higher risk of revision with a resurfacing, for example.
And he's doing it again.
Yeah, exactly. Than there is with a total hip replacement. So if you have an older patient, sometimes you want to do one procedure that may last them the rest of their life. I think the hip replacement is a more common procedure in that age group.
So if I ask you, we only have a minute left, what new procedure most excites you? Are there things that are being done right now that would wow someone? These replacements really have wowed people over the last 20 years.
Yes.
These were very awkward devices before, revisions, things, people looked like they were limping after they had procedures. Now with the engineering, people look great. What new things are in the forefront over the next 5 to 10 years?
I think the biologics is probably is very important. I think that there's a lot of research being done to try to regrow cartilage. And perhaps one day we'll be able to regrow cartilage and not have to do a joint replacement and put a prosthesis in. I think that would be exciting. I think that's still in its infancy, and we certainly are nowhere near eliminating joint replacements.
For someone who might need one, what do you think? 10 years, 5 years, 20 years?
How long they last?
No. How long do you think it's going to be before they don't need them?
Okay. I think realistically, we're talking 10 and more likely 20 years before we're anywhere near that.
So don't postpone your knee or hip replacement waiting for some magical procedure like injections or some biologic or stem cells to help you regrow your cartilage. With that, I want to say thank you, John. It's been always a pleasure. Thank you. John was my first guest.
Oh, wow.
And it's always a pleasure. Hope you come back and really enlighten us on orthopedic surgery.
My pleasure.
Thank you.